Okay, so we're going to talk about disorders of fluid and electrolyte balance and acid-base balance. So really we're going to talk about water, which is going to get us into things like osmolality or osmolarity. So if you're not familiar with that, you need to be. We're going to talk about it some here. And then we'll talk about electrolytes, which are really just ions. Sodium, potassium, calcium, those are the big ones we're going to talk about. We'll also kind of discuss chloride a little bit, magnesium, and phosphorus. So we're going to talk about some of those, and then we'll get into acid-base balance. So hydrogen, hydroxide, so oops, that's a negative, bicarbonate, those kinds of things. So to start out with talking about fluids, we have something called the intracellular fluid compartment. Well, that's just talking about intracellular fluid. So that's fluid that is inside cells. And actually, most of your fluid is inside cells. About 2/3 of your fluid is found inside your cells, of all the fluid that's in your body. And then we have fluid that's outside the cells, and that's extracellular. Okay, so that makes sense. But if you have a tissue which has a whole bunch of cells, then we give that a special name. That extracellular fluid gets a special name. We call that interstitial. Stitium refers to tissue, which is going to involve cells. Okay, so that's your interstitial. But we also have spaces like around the heart, where we have a pericardial lining, and there's fluid inside that as well. And that's not really, that's extracellular, but it's not interstitial because it's just a fluid found in a different place. So we give these a special name. We call them transcellular compartments. Cerebral spinal fluid is an example of that. It's not really interstitial, but it's still extracellular. The peritoneal cavity, where your gut is and where you have your intestines, that's all filled with fluid, so that's also there. Pleural lining, pericardial, I already mentioned. Joints are also, that would still be extracellular, but it's in a compartment. So the distribution, about 60% of the body weight in healthy male, 50% in healthy female, is the distribution of water. Here's something to remember: 75 to 80% of an infant's body weight is water, so they have more water. And I'll tell you right now, if, let's see, you have a total body water decrease with aging. So that means elderly people will have less water in mass than an adult, and definitely more than an infant. So as you age, you have less and less water. So it decreases with aging, so because there's an increase in adipose tissue, decrease in muscle mass, renal decline, more water is lost as urine, so it's not reabsorbing the way it's supposed to in the kidneys, and diminished thirst perception. That's something to kind of keep in mind, especially if you have elderly patients, that they may not be drinking enough just because they don't feel thirsty as much as they need to. So that's a person that, most healthy people, when you're thirsty, you drink and your body kind of takes care of itself. You don't have to really push fluids. But sometimes there are times where that has to be done. So let's see, I already mentioned this, about 2/3 of water is found inside cells, about 1/3 is outside cells. Okay, so that makes sense. Now, we know that we have blood, and about 1/3 of that extracellular fluid is in the plasma. And this can be confusing, not really a trick question, but it's a question that it's something that you should probably know, and people get tripped up by it. But if you really think about it, we know that we have 5 liters of blood, whatever, and we think, well, that's a lot of volume, so that must be a considerable amount. But really, if only 1/3 is extracellular and only 1/3 of that is plasma, that's really not that much. So that's a lot of times questions come up as like, where is the most water found? And blood will always be kind of a choice. And it's really not. Most of the blood, or most of the water, is found inside cells. And these transcellular compartments I was talking about, like cerebral spinal fluid and the intraperitoneal cavity, those kinds of things, that's really only about 1%. So this is a concept that a lot of people find difficult. And that's how fluid moves in and out of capillaries. And it's a really important concept because it comes up in things like shock and just perfusion of cells in general when blood pressure is low and fluid can't be perfused, or you can't perfuse your cells. So let me explain what I mean by that. Normally we have cells that are, if we're talking about interstitial, okay, normally we have cells out here, and these cells need a constant flow of fluid around them to bring them oxygen, to bring them nutrients. So there needs to be a constant flow of fluid around these cells, and that's what we call perfusion. Okay, so oxygen can be carried in that fluid, and then these cells are happy, and then they're producing waste. They're producing things like carbon dioxide, and that carbon dioxide can then go away and be carried away. So we need that to happen. So we have a couple of different kinds of forces that are taking place, and we're going to talk about the easy one first, and that's hydrostatic. Okay, hydrostatic, and that's really just what it, well, I was going to say what it sounds like, but I don't know if hydrostatic is really that descriptive, but it's pressure. Okay, so that's think about it this way: you have your heart that's pumping, that's beating, and it's pushing fluid through your vessels. Okay, so if it beats harder, if you increase your cardiac output, your stroke volume, your heart rate, then that's going to increase the pressure. Okay, so what happens then is that the fluid will be pushed out. Okay, so there are little pores, capillary pores. There are aquaporins. So there are pores within the cells. There are pores between these endothelial cells that line the capillaries, and I'm talking about capillaries here. And so if we increase the pressure, then that's going to more forcefully push fluid out, and then it's going to be able to perfuse these cells that are out here. Okay. Now, there's another force, though, okay, because if we just look at that, then we think, oh, well, all the fluid's just leaving the capillary, and some's left, but that's it. But that's not what happens, because it actually, the fluid will go out, and then it will go back in. So we have to explain how that's going to take place. What you have inside your cells, or inside your capillaries, are you have proteins, something, well, we have blood cells, but there are a lot of little proteins in here, and we kind of refer to those as colloids. Okay, so when we talk about colloids, that's usually what we're talking about, and usually the colloids we're talking about, because they have a big effect, is a protein called albumin. So albumin's going to keep coming up, and so we know, if you remember osmosis, we know that if you have a bunch of proteins in there or particles in general that can't cross, that water is going to move to where those are. That's what osmosis is. It's the movement of water when those particles can't move. So these albumin proteins, or there are other, like clotting factors and some immune proteins in there too, but these are all going to work like a sponge, and they're going to be pulling that water back in. So now we have some competition going on here. We have the hydrostatic pressure, the heart, the blood pressure that's causing, that's pushing the fluid out. But then we have this oncotic, it's also called oncotic pressure. Okay, so we have these colloids that's pulling the water back in. So we can call that colloidal osmotic pressure. So it's trying to pull it back in. Now here's the really cool trick, if you can understand this, is that if you have water initially being pushed out over here on the arterial end, okay, so this is the arterial end on the left, then water is going to be pushed out. But as the water is pushed out, I mean, at some point, you're losing water, which is going to ultimately kind of increase the concentration without any colloids or any proteins moving at all. Just the loss of water is going to increase the concentration down here on the venous end. So at some point, this reverses, and this colloidal pull, okay, so these proteins that are trying to pull the water back in will win, and so water then starts moving back into the capillary. So what we end up with, if you kind of understood what that meant, what we end up with is water, or fluid, it's mainly water, moving out, and then over here on the venous end moving back in. Okay, and that's because of this push and pull. The push being the pressure, and the pull being these colloids, these proteins that are working in here. Now, we can't I'm not just going to ignore the fact that you also have particles out here, okay, so you have colloids out here as well that are going to pull, but they're not going to pull very much, okay, so they have a smaller role. Now, if you increase these a whole bunch, then yeah, that's going to really pull the fluid out. But generally, when things are happening normally, that has very little effect. And also, you know, when you're pushing fluid into, you know, if you take a, you know, a water balloon, this is a faucet, okay, we'll just make it look like that. I don't know, that's a bad faucet. But if you're filling a water balloon with water, well, that, yeah, you've got fluid moving this way because you've got such high pressure here. But, you know, the water balloon is going to be creating some pressure too, and it's going to be pushing back. It's not going to win, but there's still pressure pushing in both directions, okay? And we see the same thing here. We see that as fluid is being pushed out, well, there's some pressure in here, so it's going to try to push back. It's just not going to win. So ultimately what we end up with is a net movement of water out of the vessel, of the capillary, especially on the arterial end, and then we have a net movement of water back in to the vessel on the venous end. Now, one thing to remember is it's not exactly equal. You actually have more fluid overall. If you do all the math and you calculate and you add all these together, you have more fluid moving out than moving back in. So the question would be, where's the rest of that fluid going? And the answer is it's going into lymph. Okay, so the lymph is going to drain that extra fluid that's being produced. Okay, so if you understand all those concepts and the push-pull, the push of hydrostatic pressure, the pull of that oncotic pressure, then this should kind of be able to, you should be able to figure out a lot of things. And I'll tell you, there are a lot of test questions that are based on this concept. I mean, if somebody has liver failure and they're not producing albumin, well, that means that you're not going to have albumin, okay? Not as much anyway, which means that you're not going to have that pull back in. So the fluid's just going to stay out here in the tissue. And do you know what we call that when fluid stays out in the tissue? We call that edema. And so, yeah, liver failure, as we'll talk about, and it might come up in this section too, just for this concept. But if you have liver failure and you're not producing edema, or you're not producing albumin, you're going to have edema all over the body, potentially. It's called generalized edema. It can happen anywhere in the body, and it's because you don't have enough of this colloidal pull. Okay, so I think I went over everything here, and we'll look at another couple of pictures here. So normally net movement of fluid is from capillaries to the interstitium. So normally we have fluid moving in this direction out of the capillary and into the interstitial tissue. Some of that will move back in, but some of that moves into the lymph and then is drained by the lymph. So fluid and proteins that are not reabsorbed in the capillaries are drained in the lymph system. So the lymph is picking up on a lot of stuff, and that kind of makes sense. If you have an infection or something like that, it'll move to lymph nodes, and then there are lymphocytes, B cells, T cells. So that's also part of your immune system, is that if you have bacteria or something that have infiltrated, then that gets swept into the lymph, and then your immune system can kind of handle that. Okay, so this is another picture showing the same thing that I just talked about, but it's showing here's your capillary hydrostatic pressure. You have filtration, so you have net movement of water out of the capillary, and then as we move down to the venous end, you have these colloids, or these proteins, will increase the oncotic pressure, or the colloidal osmotic pressure, and you're going to have pull of fluid back in, and then the excess will be drained into the lymph. So this picture is just really what I've been trying to draw. It adds here, it also shows that fluid is moving in and out of cells. Okay, so this is something to remember in this section too, is that if you have a change in something like sodium levels, then, you know, if you have more sodium out here, that's going to pull fluid out. If you have less sodium, if your sodium-potassium pump stops and sodium starts to build up inside, then you're going to have more pull of fluid inside the cell. So this osmotic potential, this osmotic pressure has to be just about, you know, you have to really, that has to be tightly regulated, and the body does tightly regulate it. Okay, so let's say that doesn't work. Okay, so we've got a problem. We have either too much hydrostatic pressure, maybe somebody is standing for a long time and they don't have good drainage, they don't have good circulation, and so fluid will start to accumulate. Okay, and we call that edema. Okay, so if fluid starts to accumulate in this interstitial space, we call that edema, or maybe it's just they got injured. Okay, and when you have an injury, it's going to increase your capillary permeability. So you know you normally have these cells lining the capillary, okay, these endothelial cells lining the capillary. Well, during an injury, they'll actually contract and allows more fluid out, and that's what causes swelling. And the swelling is edema. Okay. All right, so edema, accumulation of fluid within the interstitial spaces. It's palpable swelling. It can be localized, so like with an injury. It can be generalized, like what we talked about with liver failure and the loss of production of albumin. So those are a couple of different ways that edema can be, it can show up. Pitting edema, so there's a difference between pitting and non-pitting edema. So pitting edema means if you press on an area, which we can see in this picture down here, but if you press on an area and then you remove your finger, and that indentation remains, we'll call that pitting edema. So if we just think logically, if you push on something and you don't have good flow to that area, then it's going to take a while to refill that pit. So pitting edema really indicates that fluid flow, so we have that written here, that fluid flow to the area is somehow restricted. So we're trying to replace the fluid that was kind of pushed out of place, but if you don't have good flow, then it's going to take a while. Okay, so pitting edema, it can be graded like 1, 2, 3, 4, depending on how severe it is. But that's pitting edema, and it's it's restricted. It's restricted flow. It's just not refilling fast enough. Now there's something called non-pitting edema, which means you've got good flow to that area, but you're not getting drainage. Okay, so maybe, and that's usually what it is. It actually has another name called lymphedema. But if your lymph nodes are not able to drain that fluid the way that it's supposed to, then then you can end up with non-pitting edema. And most edema that we see is pitting edema, but you'll also come across non-pitting edema that's usually associated with some kind of lymph obstruction or a tumor or something like that that's blocking the flow of lymph. So some common causes, hopefully these, you can read through these, I'm not going to spend too much time on them, but hopefully they kind of make sense based on everything we just said. If you have increased capillary hydrostatic pressure, so that's really, it's not really blood pressure, because blood pressure has other meanings, but it's caused by the pressure of the blood, so the pressure inside the vessels. So a lot of things can cause that. Increased vascular volume, you have a lot more fluid in your vessels. Well, that's going to increase the pressure, okay, which can cause edema. Heart failure, kidney disease may lead to increased fluid retention, more fluid, more edema. Venous obstruction, that's if the blood flow that's supposed to, remember, it comes down through arteries and it tries to go back to the heart through veins. Well, if you have venous obstruction, then that fluid is going to remain. Okay, and that can cause edema. Excuse me. Decreased plasma colloidal osmotic pressure. Okay, so that's a term that sounds fancy, but you really need to understand it. Plasma colloidal osmotic pressure. Now, if you remember, albumin, or these colloids, okay, proteins, all the stuff, all these particles that are in your plasma, if those decrease, well, then you're not going to get the pull that you need, and so you're going to have fluid that remains in the interstitium. Okay, so hopefully that makes sense. And this is the example I used here. Liver disease may cause less protein secreted into the blood. Kidney disease may lead to protein loss into the urine. If you have some kind of glomerular disease, a nephrotic disease, then that means that you could have proteinuria, which means protein in the urine, and that means it's not in the blood anymore, which is going to, can lead to generalized edema. All right, increased interstitial colloidal, so that means more like maybe immune cells out here or something collecting may cause more of a pull out of the capillary, and that's going to cause edema. Increased capillary permeability, mentioned that. Like if you're injured and you have higher permeability, or it could just be damage. Or allergies. Allergies can cause that. It can cause increased capillary permeability. That means fluid's going to move more easily out of the capillary. So inflammation, allergic reactions, capillary damage from malignancy, tissue injury, burns, and then the obstruction of lymph flow. If you're not able to drain that extra water that ends up in your interstitium, then that fluid's just going to stay there, and that's also going to lead to edema. All right, so let's talk about electrolytes. Electrolytes, really, we're talking about ions, distribution of ions in the body. So ions in bone can be reabsorbed for cell function as needed. Okay, so that's just a little example there. We know that we have bone, and we know that it has a lot of calcium and phosphorus and things like that, and that if we need those things, we can reabsorb it back into the body. So I always ask what's the most important thing about calcium? Well, the most important thing is that we have the correct calcium levels for our cells, not bone. So if you don't have enough calcium in your blood, well, your body will just take it right out of the bone and put it into the blood, and that can weaken your bones. Okay, so intracellular, so ions that are found inside cells, potassium, calcium, magnesium. Potassium is really the big one. 98% of calcium is intracellular, but we also see a lot of magnesium. So magnesium is also found at high concentrations in the cells. Now, I will say about calcium, and I'll probably say it again, calcium, it says it's intracellular, which is true primarily, but it's really sequestered. It's usually found in the endoplasmic reticulum or the sarcoplasmic reticulum if it's a muscle. And so it's not in the cytosol. So there's very little in the cytosol. And then there's some outside. So you shouldn't see very much calcium actually floating around in a cell, but it will be, but most of it is in compartments within the cell. Okay. Meanwhile, potassium is just kind of floating around there, and magnesium. Okay, so extracellular, your primary, the big one here is really sodium. Okay. Okay, so sodium is your major extracellular ion. Okay, so chloride can also be found out there because it kind of goes where sodium goes. But you can also find phosphorus outside the cells as well. So about 14% is extracellular of in your body, but most phosphorus is found in bone. Okay. All right. So water and electrolyte balance. So if we kind of look at some of the numbers here, we can see here's your sodium extracellular. It's the primary extracellular. You really don't see much other extracellular concentrations of other ions. Chloride, same. It's a negative ion, but it's the major extracellular. If we look at intracellular, we like to think of potassium. So potassium is really, really important for things like cardiac function. So if your potassium levels change, the first thing you should be thinking about are dysrhythmias. You should be thinking about the heart, cardiac. That's the most important thing. Magnesium also has an effect on cardiovascular or cardiac function, but mainly with its competition for calcium. But you can see that intracellular, the main one we're going to focus on is potassium, but you can also see magnesium there. Negative or intracellular negative ions is phosphate, so you do see some phosphate. It's part of ATP, adenosine triphosphate. So yeah, you're going to find phosphate ions inside cells as well. Okay, so normal sodium serum levels 135 to 145. I'm not too worried about you knowing these numbers. That's not going to be something that I'll ask. I'll tell you if it's high or low, and then you'll have to figure stuff out from there. But sodium and chloride has the highest extracellular concentration. Essentially, your cells are floating in salt water, so that's something to remember. It's like the ocean. It's almost the same concentrations. All of these ions are almost the same concentrations as the oceans. Like our cells just kind of, moved out of the water and sort of formed their own little ocean that they're floating in. So to maintain functional sodium concentrations, if you increase sodium, you have to increase water. Now that's it. Let's kind of pause on that concept here. and say, okay, well, if I eat a lot of French fries and potato chips and I increase my sodium levels, my body's not going to be that happy with that because now my sodium levels are too high. And so the way that my body will fix that is it will try to increase water. Okay, so it's going to try to dilute that sodium because it wants it in a certain concentration. So I'll get thirsty and I will increase my water. Now I have this little arrow pointing here because I have a question down here. If I increase my sodium and my body's response to that is for the kidneys to retain water, okay, so to just keep as much water in the body as possible, increase thirst, increase water consumption, then what's going to happen is my fluid volume in my body is going to increase. If my fluid volume increases, that's going to increase the overall pressure. So that's going to lead to higher blood pressure. So if you retain sodium or if you eat too much sodium in your diet, then you're going to also retain water, become thirsty, and that's overall going to increase the pressure, and that will be seen as higher blood pressure. Okay, that's an important concept. So ions in general, sodium, we're really talking about sodium here, regulates extracellular fluid volume. So this is definitely sodium because potassium regulates intracellular volume and osmolarity. All right, so maintaining fluid volume, I already mentioned this a little bit, thirst, but there's something else should have been covered in physiology, but we'll review it quickly here, and that is antidiuretic hormone or vasopressin. Okay, so that's one of the two that are produced by the posterior pituitary. The other one is oxytocin. Those are the only two hormones that are produced by the posterior pituitary. And what that does is it causes in your kidneys, in your renal tubules, remember you've got the proximal tubule, you have the descending loop of Henle, the ascending, you have the distal tubule, and then you have the collecting duct. Okay, so that's how filtration, well, not filtration, but that's how your kidneys work, basically. Filtration, and then you have reabsorption, those kinds of things. So what happens is with antidiuretic hormone, ADH, what it does is when it's released, it allows this collecting duct, primarily, also somewhat in the distal tubule, but it allows it to reabsorb water. Okay? So that's a way to control how much water is in your body, fluid volume, fluid levels of your body, is by you increase antidiuretic hormone, and now normally what happens is whatever's left in these tubules, and there are millions of them, or a million, but normally the fluid that's left becomes urine. Now a diuretic causes an increase in urine. So if you have if you're taking a diuretic, or if a patient is taking a diuretic, normally it's because they have blood pressure problems. And so you're trying to get rid of the fluid. Well, antidiuretic hormone is antidiuretic, so what that's going to do is it's going to cause reabsorption of more water back into the body, and that's going to increase pressure. It's supposed to be an up arrow. So that's going to increase blood pressure, the release of antidiuretic hormone. Okay, so so if you have less ADH, then your blood pressure can drop, and if you have more ADH release, then your blood pressure is going to be higher. Okay. Yeah. So excessive thirst and urine production can also change your fluid volume overall. I mean, that makes sense if you're either taking in more or less water, or you're urinating more or less, then that's just pretty clearly water changing levels. So maintaining sodium levels. So we also have the renin-angiotensin aldosterone pathway. If you remember what that is, it also works at the, oops, I erased my nephron, but it also works kind of at the distal tubule. And what it does, so it does a lot of stuff, but renin is produced by the kidney, and it causes this thing called angiotensinogen. I'll just put angiotensinogen to be converted into angiotensin 1, and then angiotensin 1 is converted by something called angiotensin converting enzyme to angiotensin 2. Okay, so angiotensin 2 is active. And one of the things that it does is it causes vasoconstriction, but another thing that it does is it causes the release of aldosterone. Now, what aldosterone does is it comes here and it increases sodium. It increases sodium-potassium pumps. And what that will do is it will cause sodium to be reabsorbed. Okay, erase that. So it causes sodium to be reabsorbed. Well, we know that osmosis happens, and so if more sodium is being reabsorbed, then what happens is more water will be reabsorbed. Okay, so that's, there you go. That's control of water and sodium at the same time. So this RAA pathway, so usually that's what we'll abbreviate it to, RAA, the renin-angiotensin-aldosterone pathway, ultimately will cause the increase in reabsorption. So increase of saving, putting back into your body sodium and therefore water, because water will follow it. Now we also have some other things, sympathetic nervous system. Remember adrenaline, that's your fight or flight, that's sympathetic. Adrenaline, another word for adrenaline, of course, is epinephrine. Okay, so I'll just put epi. But that's your fight or flight. It causes vasoconstriction, which is going to increase blood pressure, increases sodium reabsorption, because it also can activate sodium-potassium pumps. So all of these things can have an effect on water and sodium concentrations. So what if we don't have enough sodium? So decreased serum sodium levels, deficits in kidney function is often the cause. Drugs, disease, age, lots of different things can cause your sodium levels to change. So sodium deficits caused by plasma or fluid hypoosmolality is something else. That means that if you have too much water, then your sodium concentrations will be decreased. I hope that makes sense. I mean, you could have, 5 sodiums here, but if you have those 5 sodiums, but you have a whole lot of water, well, that means your concentration is going to be lower. Okay, so even though you can not change the number of sodium atoms in your body, but if you flood it with water, that's still going to lower the concentration overall. It's like diluting lemonade. You can have it in a 2-quart pitcher, or you can have it in a keg, but if you just have the same amount of lemon, it's going to be really watery. I don't know how I came up with that, but anyway, a keg of lemonade. That's a party. So sodium deficits cause fluid, so that's what we're talking about here. If we don't have enough sodium, then you can have too much water, essentially overall. So normally, remember, our fluid or our sodium is supposed to be at a high concentration outside the cell. If you don't have enough of that sodium, then what happens is it's very dilute out here, and this is an important point, and I hope you understand it. But if we don't have enough sodium out here, well, what's going to happen is water is going to move into these cells, okay? And these cells are going to swell, okay? And that's not good, and we'll talk more about that. So the causes can be caused from pure sodium loss. So sweating, a lot of times when you sweat, it's sodium and water that you sweat out. If you just replace it with water, then you're going to have an overall loss of sodium. Low intake, dilutional hyponatremia, that's just a fancy word for drinking a lot. Okay? Drinking a lot of water, or water being retained for other reasons. So hyponatremia, remember, hypo means reduced. Okay, that means low sodium. Okay, so remember, sodium is involved with action potentials. Do you remember that? If you have a neuron, remember that action potential is sodium rushing in. Well, if your sodium levels are low, then you're not going to have good action potentials. That's not going to work the way that it needs to work. So sodium is involved with action potentials in neurons. It's involved with action potentials in muscle. Okay, so that means you could have cramping, you could have neurons that aren't functioning the way that they're supposed to, and you have this osmotic thing that we were talking about, these osmotic effects. And really, that's one of the biggest, most life-threatening things that can occur with hyponatremia is cerebral edema and increased intracranial pressure. But you will also see, because of the other effects of sodium, you'll also see things like lethargy, confusion, decreased reflexes, seizures, coma. Okay, so you also see these neurological effects as well. So if it leads to a loss of extracellular fluid, and if it leads to a loss of extracellular fluid and hypovolemia, okay, so if we have loss of extracellular fluid, so we don't have as much fluid out here, then, and it may pull it from the vessels as well. Okay, so now we have a shift of fluid into cells. Then what can happen is you may end up with hypotension, tachycardia, decreased urine output, a lot of things because of this osmotic effect that sodium has as well. If dilutional from excess water, you'll see weight gain, you'll see edema, ascites. Ascites is just a collection of fluid. Normally we talk about that happening in the peritoneal cavity. It can also happen in the liver, but ascites is just an increase in fluid around in a certain area. And jugular vein distension, so that's something you can actually view. You can look at the jugular vein, and if it's distended, then that may mean that there's too much water, or that fluid is not being handled the way that it needs to be handled. So hyper, so that's too much, so that's high sodium. Hypernatremia, so increased sodium levels. High sodium causes an increase in extracellular fluid tonicity. So remember, so it's going to be, remember this word, hypertonic. Okay, so now we have too much sodium out here. So remember what happened when we didn't have enough sodium, that cell swelled. So it logically makes sense now that the cells will shrink if we have too much sodium. So it's going to pull it out. So generally caused by decreased water intake, makes sense. If you don't have enough water, your concentration of sodium is going to be too high, or increased water loss. More common in infants and those who can't express thirst, because normally we will get thirsty and we will try to replace that fluid. We'll also have the antidiuretic hormone, or the vasopressin, that's going to cause us to retain more water. Okay. So also hypodipsia is, well, we already said who can't express thirst. But in certain people, the inability to express thirst, then that's somebody that's going to have to sort of monitor their water intake. All right, so manifestations, well, this makes sense. Dry skin, decreased tissue turgor. Okay, so that's just how much fluid is in your tissues. That's going to be decreased. Decreased salivation, elevated body temperature, because you aren't going to be able to control your body temperature as easily. So water excess may be, so this is when you just simply drink too much water, or you have too much water in your body. Usually, or oftentimes, it's caused by compulsive water drinking. So there are people who want to drink. They have to be, you have to keep an eye on them because they just want to drink water. They'll drink out of the toilet if you don't stop that from happening. Okay, and they will drink to the point that they die. Okay, so this can cause death. So it can cause by compulsive water drinking. Decreased urine formation, so this could be a kidney problem. And there's something called syndrome of inappropriate ADH. Now, we've already talked about what ADH is. It has the other name vasopressin. And we know that when vasopressin, or ADH, is released, we'll say ADH here because we're talking about it as a diuretic. So when vasopressin is released, that it causes increased sodium or water reabsorption. So we have more water in the body. Okay. Well, so syndrome of inappropriate ADH is ADH secretion in the absence of hypovolemia or hyperosmolality. So that means that the ADH is being secreted and there's really no good reason for it. So it's very inappropriate that it's doing that. So syndrome of inappropriate ADH, and so the water is being reabsorbed and now we have too much water. Okay, so that's something else that can take place. And so you'll end up with hypervolemia, so too much fluid overall in your body, but you also have hyponatremia. You don't have enough sodium to offset that. Okay, so your osmolarity is messed up. So manifestations, there we have that cerebral edema, so swelling in the brain, confusion and convulsions can happen, weakness, muscle twitching, nausea, headache, weight gain. So we see a lot of neurological types of symptoms there. Okay, let's talk about potassium. So normal serum level, 3.5 to 5.0. Again, on an exam, I will tell you whether it's high or low. You will ultimately have to memorize that, but I'm more interested in understanding the pathophys here. So potassium in general maintains intracellular osmolality. So remember, or osmolarity. Osmolality is just an actual number. Osmolarity is I don't know, more of a concept, so I kind of use those interchangeably. So milliosmoles per liter. But normally potassium is inside the cell and sodium is on the outside of the cell. And so that's, you know, in general, we have a good homeostasis and everything works properly. So, but if you have changes in potassium, and here's an important thing to remember, because potassium lives primarily inside cells, even if when your serum potassium levels become either high or low, it will ultimately change the intracellular concentration, okay? So if your serum levels are low, then it very directly will cause your intracellular levels to be low. Now remember, one of the things that potassium does is it helps us maintain our resting membrane potential. Remember, it has to reach threshold, and then we have an action potential. Okay, so this is normally around -70. And so if you have low potassium, then what will happen is this will kind of go up, maybe to -65 or -60. And then you're going to have I'm sorry, if that's too much. So if you have too much, because it's a positive ion. So if you have too much of this, then inside the cell, because your serum levels or your plasma levels, same thing, essentially. So your plasma levels, if those are low, then what will happen is it's not going to be very excitable, okay? Because you're going to be missing a lot of these positives. So it's going to have to work harder to have an action potential. If you don't really understand that, you might want to kind of review that. But yeah, your potassium is one of the main players in maintaining this resting membrane potential. If you're down here at -80, that's a neuron or a muscle that's going to have a really hard time reaching threshold. It's going to have a really hard time firing. Meanwhile, if you're up here at like -60, which you might see with low potassium, then let's see, do I have that right? Potassium is positively charged. If we don't have enough positive, it's going to be more negative. So that would be if you have too much potassium. Okay? If you have too much potassium, you're going to be up here, and you're going to be a little twitchy. Okay, so that's kind of what this comes to. So maintains intracellular osmolarity, controls cell resting potential. So your cell resting membrane, your resting membrane potential. So high serum potassium leads to more movement of potassium into cells, which means that it's going to constantly kind of be depolarizing. If you really load up with sodium or potassium, then you can cause neurons to fire without anything. So without any kind of stimulation or very little stimulation. So high potassium leads to more movement of potassium into cells, overactive neural responses. Cells are usually at about -70. Cells in general are very sensitive to potassium changes, and there is nowhere more relevant for life, you know, an emergency type of situation when potassium levels are off than the heart. Okay, so this can cause dysrhythmias, and people can die from this. So essential for transmission and conduction of nerve impulses, normal cardiac rhythms, and skeletal and smooth muscle contractions. So being twitchy is one thing, but you don't want your heart to be twitchy. That's not good. Okay, like VFib or even AFib. Okay, fibrillation. We'll talk about it with cardiovascular. So concentration maintained by the sodium-potassium pump in general, and there's also a direct relationship between potassium and pH because potassium, when potassium levels are high, what happens is potassium will move into the cells, and then what it will do is it'll boot out the hydrogen, and it can go the other way. When your pH is low, it'll kick the hydrogen out. So they're constantly kind of, I don't know, fighting for turf in there. All right, so, and I'm going to mention that again here because there it is, the potassium-hydrogen exchanger. But controlled potassium is connected to sodium and hydrogen, so sodium-potassium pump. Okay, so remember we saw that earlier, so you know what this is. But the sodium-potassium pump, where you pump sodium one direction and potassium the other. So that means that as we regulate sodium, we're also kind of regulating potassium and vice versa. So the sodium-potassium pump activation by aldosterone in the kidney. So aldosterone is going to affect both potassium and sodium, but they move in opposite directions because one's being pumped in, one's being pumped out. Epinephrine and insulin increase the sodium-potassium pump activity, so epinephrine can have effect on both sodium and potassium. And then there's this potassium-hydrogen exchanger that's found in certain cells. So if you have, so we can look at this and we can say, and this question is kind of important, what effect might high serum potassium levels have on pH? Well, if here's a cell and we have high serum potassium, then what's happening is that potassium, remember, will move into the cell. Well, guess who gets booted out at the same time? Hydrogen. Okay. Now, if we have a buildup of hydrogen, what's that going to do to our pH? It's going to lower it because pH is weird and backwards. But that's going to lower pH. So high potassium levels can cause acidosis. Okay, so they can cause your pH to fall and become more acidic. All right, so potassium levels. Change in pH affect potassium balance. Yes, because of that exchanger. So that's true. Hydrogen ions accumulate in the intracellular fluid during states of acidosis. Potassium shifts out. Okay, so in this case, we've got hydrogen that's kind of booting the potassium out. Well, that's going to lead to hyperkalemia. Okay, this is a difficult concept, but it's not an impossible concept if we just cut down to the most simple thing and say, as potassium goes in, hydrogen goes out. As hydrogen goes in, potassium goes out. Okay, so if we just remember those things, that they kind of move in opposite directions, then we can say that, you know, let's see, during states of acidosis, well, we've got too much hydrogen. Okay, so the hydrogen, oops, that's this case. So hydrogen is moving in here, which means potassium is moving out. So now we have hyperkalemia. Okay? And if we read on, we're going to see, yep, there it is, hyperkalemia. So aldosterone, insulin, epinephrine, these all influence serum or plasma potassium levels. So the kidney is the most efficient regulator. So potassium can adapt. So if potassium levels change slowly, then you know, you won't have you're less likely to experience some of the dysrhythmias and things like that associated with changes in potassium level. But if it's a acute or a very quick change, then yeah, that's much worse. So hyperkalemia, increased extracellular fluid potassium levels greater than 5, caused by excessive intake or decreased excretion in the kidney. If you eat too many bananas, I guess, it's really rare, or decreased excretion. Manifestations initially causes hyperexcitability, but at very high levels of potassium. I mean, if you're, you know, yeah, if you're normally here at -70, okay, and then, you know, you have too much potassium, so it goes up a little bit, then yeah, that's a hyperexcitable cell. It's already partially depolarized, so it's quick to depolarize. But if it goes clear up here and it's really close to threshold, I know that's not a very good graph, but if it's already really close to threshold, then you may not be able to repolarize the cell. I mean, you're just going to have cells that aren't working at all. Okay, so initially causes hyperexcitability, but at very high levels of potassium, the membrane potential approaches threshold and may prevent repolarization, subsequently depolarization. It'll just kind of shut down the cells in general, and that's very bad, again, I repeat, especially in the heart. Okay, so that's your biggest concern. So it can cause weakness, fatigue, muscle cramps, and decreased cardiac response. That's not something we want to see. But it's rare. Hyperkalemia is rare because of efficient renal excretion. But there's also hypokalemia, that's less than 3.5. Notice that the levels like 1.45 for sodium, or 145, I think that's what it was. Hypernatremia. Okay, well, 135. Well, yeah, I think it was 145. Okay, I'm just wasting time. This is already a long lecture. But anyway, you notice that it was that potassium or sodium is really high, and that's because it's outside the cell. Sodium is really high because it's an extracellular ion. Potassium, the levels are really low, and that's not because we don't have any potassium, it's because it's inside cells. Okay, so we don't really see it as much in the blood. Okay, but there is potassium there. Obviously, it's just found inside the cell. So that's something that will actually help you learn these numbers when you need to. So potassium balance is described by changes in plasma potassium levels, which makes sense. Plasma potassium levels causes reduced intake of potassium. So we're talking about hypo or reduced. Reduced intake of potassium can cause it increased entry of potassium into cells. Okay, so that when might potassium move into cells? Well, maybe when hydrogen is moving out of the cells. Okay, because of that exchange. Insulin also has an effect. Increased loss of potassium may also take place. So manifestations depends on the rate and the severity. So membrane hyperpolarization means it's too polarized. We're going the other way now. So if our membrane potential was normally -70, we're clear down here. That means it's like go, neuron, fire, and the neuron says, oh, I'm trying, I can't do it. It has to go all the way up here before it can then fire an action potential. That's crooked. Okay. Membrane hyperpolarization, I know depolarization, hyperpolarization means it's way too polarized, it's way lower. Causes a decrease in neuromuscular excitability, skeletal muscle weakness, smooth muscle atony, which means you don't have good muscle tone in your, and it's talking about smooth muscle, and cardiac dysrhythmia. So there we go again. So hyperkalemia, hypokalemia, both of these. Amiodarone is a drug that's used a lot for cardiac dysrhythmias, and it works on potassium channels. Okay, so blood potassium levels control that resting membrane potential, so we remember that. Makes neurons and muscle cells more excitable. That's what hyperkalemia does. Hypokalemia is going to make them less excitable, but either way, they're going to, it can result in cardiac arrhythmias. And here are some examples. We're not really looking at EKG strips right now, but that's what this is telling you. So I'm driving that home once more, that cardiac arrhythmias from hyper and hypo are the most serious effects. So related depolarization and repolarization effects, and that's what this is showing. Hypokalemia, and then this is hypokalemia here, and then normal, hypo, and maybe my normal is this one. This is hypo, this is hyperkalemia. Okay, and here are just some other examples of how this can change, but we're not really concerned about reading, like I said, EKG strips right now. Okay, so let's quickly go through calcium. Sorry, this is so long. Calcium, 99% of calcium is located in the bone. Okay, that's where most of it is found. Necessary for structure of bones and teeth, so it is important. Blood clotting, it's like a cofactor for a lot of different clotting factors, so you need calcium for that. Hormone secretion, cell receptor function, intracellular signaling. This is a big one, this intracellular signaling. So how do we control it? Well, something called parathyroid hormone. So there's these little nodules that are found on the thyroid gland that can produce parathyroid hormone. So parathyroid hormone can increase calcium reabsorption into the blood from bone. So this is good for the cells, but it's bad. It can be bad for the bone if you have, you know, a deficit in calcium in general. So that's what parathyroid or PTH does. So normal calcium levels are 8.5 to 10.5. Again, you don't need to know the number. Extracellular, they can compete with sodium. So blocks sodium gates in the nerve and muscle cells, which is going to reduce firing. So there we have neurological function. Again, neurological function. So calcium does have an effect on that. So different calcium levels, because we kind of depend on that competition to make everything normal, but it works just right in this range. If it gets too high or too low, it's going to change things. Leaks into cardiac pacemaker cells, causing them to fire. So high calcium levels can cause increased firing of the pacemaker cells, so tachycardia, increased rhythm, cardiac rhythm. So intracellular, needed for all muscle contraction, acts as a second messenger. It's a big one. Besides the ones we've already really learned, acts as a second messenger in many hormone and neurotransmitter pathways. And parathyroid hormone, PTH, is a primary regulator of calcium by increasing absorption in intestine and reabsorption from the bone. So what if you remove the parathyroid gland, well, then that's going to obviously have an effect on your calcium levels. All right. Or control of calcium. So hypocalcemia, the cause is inadequate. Yeah, if you don't have enough calcium, hypo, so that's going to be reduced calcium. The cause is inadequate intestinal absorption. You can't absorb it. Deposition of ionized calcium into bone or soft tissue, so it's collecting in the bone instead of being in the blood where you really need it. Blood administration. So which we'll talk about that kind of when we talk about clotting. So decreases in parathyroid hormone and vitamin D can cause hypocalcemia because you're not going to be able to reabsorb it from in the kidneys and from the bone. Nutritional deficits, yeah, that kind of makes sense if you're not getting enough of it in your diet. So effects, increased neuromuscular excitability, so tingling, muscle spasm, particularly in the hands and feet and facial muscles. Intestinal cramping may occur, hyperactive bowel sounds. So these can all be associated with not enough calcium. Okay? You don't have that competition with the sodium, so the sodium is just kind of running rampant. Severe cases show convulsions and tetany, and then you can see EKG changes. This mentions a prolonged QT interval. And cardiac arrest, the heart can stop. All right, hypercalcemia, that would be hyperparathyroidism. Make sure you understand that. When the thyroid gland, oops, that's a weird looking thyroid gland, got a little problem there. But the parathyroid kind of sits here and releases parathyroid hormone. And parathyroid hormone is going to cause reabsorption of calcium from bone. Okay, so if you have this occurring too much, hyperparathyroid hormone, too much of this means that you're going to have more calcium reabsorbed from the bone. Again, that's going to weaken the bones too. Okay, so excess vitamin D can cause it. Many tumors will produce parathyroid hormone. Neoplastic disorders, things like that, can cause. No, that's not right. But yeah, there are tumors that can produce parathyroid hormone. So it affects many non-specific fatigue or effects: fatigue, weakness, lethargy, anorexia, nausea, constipation, impaired renal function, kidney stones, renal calculi can happen from because a lot of these stones are calcium containing. Dysrhythmias, again, this is always important. Anytime you see dysrhythmia and you see like, oh, what's the most important thing that you're going to monitor as a nurse? Well, you're going to monitor cardiac rhythm. Okay, so at this point you don't care if their fingers are tingling. You don't want their heart to tingle, stop, or something like that. So bone pain can happen, osteoporosis can happen. Yeah. But yeah, so phosphorus, we're not going to say too much about phosphorus. It's primarily found in bone and ATP. Okay, it's involved in glucose, fat, protein metabolism, DNA, RNA, phospholipids. They're just all of these things have phosphorus. So phosphorus is an important molecule. It's important for red blood cell, white blood cell, platelet function, and it also, phosphates can also work as an acid-base buffer. Okay. So magnesium is another one. It blocks potassium exit from cardiac cells, so it's affecting. So it has a neurological effect, and it can actually affect cardiac rhythm. Okay, so really, we're worried about potassium, but yeah. Normal level is 1.3, cofactor and enzymatic reaction. So it does a whole bunch of different things, but it can also affect repolarization. So these neurological manifestations are kind of important. It competes with calcium to block calcium receptors because they're both 2+, they're both divalent cations. And it can function, therefore, as a smooth muscle relaxant. And without getting into too much calcium is required to release neurotransmitter. If magnesium is high, then it's not going to, it's going to cause that to not really take place as easily. All right, so let's finish this off. It's already long, but let's finish it off by talking about acid base. Now this is a number you need to know, 7.35 to 7.45. So we need to remember this number. Normally, the body very tightly regulates acid-base, and it does it in a few different ways. First of all, we have blood buffers. The kidney can control it. Respiration or ventilation, breathing can control pH. So we're going to talk about all of these things. So normally, it's between 7.35 to 7.45. And if you don't remember what pH is, it's really just if you have more hydrogen, which hydrogen is just it's a hydrogen atom that's missing its electron, so really it's just a proton. Okay, I don't know if you remember this, but yeah, you have your nucleus with a proton, and then hydrogen is just one little electron that's orbiting it. Well, if you lose that electron, the only thing you're left with is a proton. And that's important because a lot of times we'll talk about things like proton pump inhibitors. Okay, well, a proton is just this. A positively charged hydrogen is just a proton, and that's because it's such a simple atom that if you take away that little electron, you're left with a proton. Okay, so I've said that a couple of times. So if you increase hydrogen levels, then you're going to decrease pH. If it's less than 7.35, then we're going to have acidic blood or acidosis. If you decrease the hydrogen, you're going to have an increase in pH, which means you're going to have, so if it's above 7.45, it's going to be alkaline blood or alkalosis. Okay, so large shifts. If it falls too far outside these ranges, less than 6.9 or higher than 7.8, then that's really not sustainable. So body acids can result from volatile acids like carbonic acid. And when we say volatile, that just means that it can move into a gas form. Okay? This should make you perk up a little bit and say, oh, gas form. Wait, is that important? Do I care about that? Yeah, because we're talking about breathing. Okay. So that's how pH is controlled by ventilation. Okay, so can result from volatile acids like carbonic acid. It's volatile because it can be eliminated by the lungs, and it will be eliminated as CO2. And I'm going to show you a chemical formula here in a second that you actually have to understand. So, or from non-volatile substances like sulfuric, phosphoric, sulfuric acid, phosphoric acids, hydrochloric acid, which is, your stomach acid. All of these things can also contribute to pH. Okay, so pH in general, hydrogen must be buffered or it has to be eliminated by the kidneys. Well, if it's too high. So let's look at this nice, fun, complicated picture. Control of pH ordered from fastest to slowest. So what controls? So if you swallow a bunch of acid, or if you get pumped with like a lot of chemotherapy drugs, have to be dissolved in a low pH or an acidic medium. Well, you've got blood buffers that will immediately soak it up. So let's look at this. This is carbon dioxide plus oxygen. We're looking at this this formula right up here at the top. So carbon dioxide, when it combines with water, it produces something called carbonic acid. Now, if we were to have fun with our chemistry and we were to count all the HCs and Os, we would see that they match up. Okay, so there's one carbon, there are 2 hydrogen, and there are 3 oxygen. 1, 2, 3. Okay, so that matches up, but that's what it forms. It forms something called carbonic acid. Well, that's fine. Okay, but really when we talk about pH, we're talking about this free hydrogen, and that last hydrogen can break off, become free, and now we have a lower pH. Okay, just because we have that free hydrogen. Well, that can go the other way too. Let's say that I put a bunch of hydrogen in the system. Okay, well, if I have bicarbonate, which is what this thing is here, this HCO3 minus, well, if I put a bunch of hydrogen on there, well, then maybe I can just combine it with the bicarbonate, make carbonic acid, and then I can just breathe a little faster, and start dumping it this way. I can make this whole equation move in this direction if I want to. If I want to breathe faster and blow off this carbon dioxide, then I can just keep this thing moving in this direction, this equation. Okay, so that's kind of how, well, I kind of jumped into pulmonary ventilation, but in general, the blood buffers work by saying, oh, you got an extra hydrogen? Look, I have a bicarbonate. I'm just going to bind with you. I'm going to go over here. I'm going to make this thing called carbonic acid, and that hydrogen just kind of goes away because now it's part of this molecule. That's how blood buffers work. That's how buffers work in general. Okay, so your blood buffers, adding hydrogen or bicarbonate, it can go the other way too, but by combining these, we get rid of them. So blood buffers in general, what you really need to know is they resist changes in free hydrogen molecules. Free hydrogen, and they're just any kind of molecule. In this case, this is your main blood buffer, bicarbonate, but they react with and absorb that free hydrogen. So adding hydrogen or bicarbonate to this equation that I just mentioned would cause them to bind with their partner if there are any available. So making bicarbonic acid. So the overall free hydrogen would not change within a range, but when they've all been bound and you've got too much hydrogen and all of these guys, all of these bicarbonates are used up, then you've got a really big problem. Okay. All right. So the overall free hydrogen would not change within a range when that range would be when they've all been bound. Okay. So pulmonary ventilation. Well, what we do is we end up breathing faster when our pH gets lower. So when we start building up these hydrogen ions, our pH is, our blood is becoming more acidic, then what we're going to try to do is get rid of that carbon dioxide, push this equation in this direction, we blow off the CO2, and we keep things moving. So we can absorb these hydrogens. These hydrogen bind with the bicarbonate forms carbonic acid, and then those can break apart and we breathe out the carbon dioxide. That's really cool. So pulmonary ventilation changes carbon dioxide of blood, and therefore it can change the pH. Remember, if you hold your breath, this is just true, if you hold your breath, stop breathing, your pH will go down. It'll become more acidic. Okay. And the way to remember that is CO2. As CO2 rises, pH goes down. Okay. So it's an inverse reaction. So yeah, when you hold your breath, your CO2 levels are going to get higher. Therefore, your pH is going to go down. Okay. If you breathe very, very rapidly, then you're blowing off the carbon dioxide. Your carbon dioxide levels are going to get lower, and therefore your pH is going to rise. So we can control our pH just by breathing. So now the kidney's a little more straightforward. They can just excrete or reabsorb bicarbonate or hydrogen and other metabolic acids, hydrochloric acid, sulfuric acid, phosphoric acid. So the kidney can also control pH, but it's this, the blood buffer is the quickest, but this pulmonary ventilation is the one that we're going to spend a little more time on. So other buffering systems, hemoglobin, there are proteins, albumin. Remember we mentioned that earlier. Proteins, they tend to have negative charges, so they can also kind of suck up some of this hydrogen if they need to, but they don't like to because that changes their function, which isn't so important for albumin, but it can be important for other proteins. And then I already mentioned renal buffering, where they just kind of secrete hydrogen or bicarbonate to control the pH. So we end up with something called acidosis and alkalosis. Now this is something you're going to have to really think about, spend some time with maybe. So there are 4 categories of acid-base imbalance. Respiratory acidosis. So let's have, I wish we could have a little quiz here, and I know there's a way, but I don't have it set up on this. But respiratory acidosis, what again happens when you hold your breath? When you hold your breath, your blood becomes more acidic. So that means your pH gets lower. Okay? And that's because your hydrogen levels build up. That's what's going on. So, and you're pushing that equation that we looked at earlier to the right, and that's going to cause more free hydrogen. So that's respiratory acidosis. I mean, you can cause respiratory acidosis by holding your breath, or it could happen from a patient that is having pulmonary issues, pulmonary concerns. Okay, so elevation of PCO2 as a result of ventilation depression. If someone can't breathe, doesn't breathe, or has COPD, those can all affect pH. Respiratory alkalosis would be something that would be caused by hyperventilation. When we hyperventilate, we're breathing too fast, then what happens is you start blowing out, breathing out more carbon dioxide. Your carbon dioxide levels of your blood fall, okay, because it's all being blown out into the air, and which is going to, remember, it's inverse, which is going to cause your pH to go up. That's alkalosis, okay? Now, there are other things, metabolic, that have nothing to do with respiration. So depression of bicarbonate or an increase in non-carbonic acid. Things like diarrhea. Diarrhea, you may lose a lot of bicarbonate. That can happen, which can cause acidosis. Metabolic alkalosis, so what if you eat an entire packet of Tums, which has bicarbonate in it? Well, that's going to cause alkalosis. Usually these things happen because of some kind of kidney malfunction, but there are a lot of things that can cause it, and it's independent of the it's independent. Sorry, it's independent of the of respiration. Okay. So why does pH change? So respiratory or volatile acid. So this is that calculation that, or this equation that I was talking about earlier. Carbon dioxide plus water goes to carbonic acid, and then that carbonic acid kind of splits and causes hydrogen to form. So an increase in carbon dioxide pushes the reaction to the right. I've already mentioned this, so this kind of review. Increase in carbon dioxide pushes the reaction to the right, increases your hydrogen content, which is a lower pH. Increases bicarbonate ion as well. Okay, so these are your blood gases. So you can measure these things. You can measure pH, you can measure bicarbonate, and you can kind of, in carbon dioxide, and you can kind of get an idea as to whether this is respiratory or metabolic that's causing it. So an increase in bicarbonate would do the opposite. It's going to push it in to the left in this direction, and that's going to increase your pH. Okay, so you can also do that by blowing off the carbon dioxide. So I've already kind of mentioned most of this. So let's look at it one more time. I've kind of explained it, but we'll look at it one more time. So respiratory acidosis and alkalosis. Respiratory acidosis, that's going to be an increase in carbon dioxide. Hopefully we understand that. If we increase our carbon dioxide, higher CO2 is going to lead to a decrease in pH, which is acidic. Okay, so the reaction goes to the right, increase in carbonic acid, which is going to then break apart, and you're going to have higher hydrogen levels. You are also going to see an increase in bicarbonate, but because pH is measuring hydrogen, your pH will be lower, and it's going to be acidic. Okay. Respiratory alkalosis, it's a decrease in decreased carbon dioxide, so your carbon dioxide levels may be blown off. The reaction goes to the left, and you're going to have a higher pH. Okay? Because these are going to combine together, that hydrogen is going to go away, and your pH is going to become higher. All right, metabolic. So metabolic acidosis, increased levels of keto acids from lipid breakdown. Okay, so that's a pretty specific example there. But as you break down triglycerides, then one of the things that are produced are ketones or keto acids. Okay, so that's acidic. Now, here's the question. Did that come from ventilation? Did that come from breathing? Does that have anything to do with breathing? No, it doesn't. So that's why it's called metabolic. It's some kind of metabolic process that's causing it. Same thing with lactic acid. We mentioned earlier that if you don't have enough ATP, or you're working your muscles too hard, you'll have a buildup of lactic acid, and that's going to cause a decrease in pH. Does that have anything to do with breathing? No, so it's metabolic. Can you fix it by changing your respiration rate or your ventilation rate? Yeah, you can. You can compensate, but the cause of it is metabolic. So metabolic production of sulfuric acid, phosphoric acid, so anything really that's going to lower your pH that doesn't have anything to do with ventilation. So decreased bicarbonate levels overall, any of these things can cause it. So metabolic alkalosis, so decreased hydrogen levels, so increased bicarbonate levels, so some antacids can cause that. Has nothing to do with ventilation, so we're going to call it metabolic. Intake or ingestion of something, vomiting, so when you vomit you get rid of hydrochloric acid, so if you get rid of hydrochloric acid that's going to cause your pH to go up. Has nothing to do with ventilation, so therefore it's metabolic acid or alkalosis. So kidney, GI malfunction, kidney's a big one, serum electrolytes, chloride, all of these things can contribute. So a test question is going to somehow give you a scenario, and you may have an increased ventilation rate, but your increased ventilation rate may be a compensation to in the case of increased ventilation, you're going to raise pH. So that could be a compensation for acidosis. Okay. All right. So, so again, this is just another graph kind of saying the same thing. So acidosis, pH is low, increased acid or decreased base. If it's respiratory, increased acid secondary to hypoventilation, okay, which is a retention of carbon dioxide, and that's going to, sedation can cause that, CNS disorders, neuromuscular disease. So the tricky thing is going to be saying that, you know, your patient is a COPD patient and they have, you know, acidosis. So what's causing that? Well, you know, is that respiratory? Well, yeah, it's going to be respiratory because they have COPD. So something like that. Metabolic, again, severe diarrhea can cause the loss of bicarbonate, increased acid production, diabetic ketoacidosis, anaerobic metabolism. So kind of the same things, just repeated on the alkalosis slide. And wow, this was a long lecture, but we're done.